Hi, I'm Goncalo Abecasis. I'm glad you're joining us by video. We're just about to start the second Precision Health Town Hall here at the Michigan League. It's got to be an opportunity to learn about planned University of Michigan precision health efforts, hopefully to also learn how you can be engaged and contribute. Our goal to make this a success is to really get as many ideas, as many different people coming in and applying it broadly to understand human health and to improve how we deal with it. Thank you. All right. Welcome, everybody. This is the Precision Health Town Hall. It's an amazing turnout. I guess if this is not where you plan to be, I hope you're near the edges, or you might be stuck here for the next hour. As you see, we have a great plan to ply you with food so that you'll be sleepy and receptive to the messages we're going to implant. More seriously, the goal of this is really to have a town hall to both present a sketch of the vision for precision health at Michigan, but also to get your feedback. With so many people, and to try and get a chance for everybody to contribute their voice and opinion, we're going to try and use a little bit of technology. We'll see if it works. Usually it does, so hopefully it'll go well. And so lunch, hopefully you all got your lunch. Then we're going to talk about precision health. We're going to have a little bit of time for completely open discussion. And then if we finish on time, hopefully this will be the start of some new connections for all of you, and certainly we hope that all of you will stay engaged and connected to us, because the reason it's exciting to do precision health at Michigan, it's because we have such a rich faculty, such a rich diversity of approaches and opinions, and it'll be much better for you being in it. Okay, here's the technology that we're going to try. If you have a phone, I guess in class it's usually bad behavior for students to be on their phones. Here it's got to be encouraged and allowed. If you text "Go Blue" to that number, 22 and 3 threes, or if you have a computer, pollev.com/Go Blue, then as questions come up, you'll be able to participate. Now, to see if the thing works, and actually just a little disclaimer, I know that many of you are experts, and I'll have it back. Just one second. I'll have it back. I know that many of you know how to do proper polls. This is not going to be a scientific poll. It's just meant to facilitate discussion. Okay, the key numbers are at the top there. So if you're texting 22333 and Go Blue, and then you can choose one of these options. And if you are using a computer, pollev.com/Go Blue. And the question here, what primarily drives you? Is it research, education, service, all three? Is it a question of just paying the bills? And so everyone is obviously being very honest and driven by the fullness of the university's mission. And you see a very majority opinion there for D. Hello. Now some. Okay, and so this is just to check. The technology looks to be working. Nobody here says that they just come in to pay the bills. That gives us a framework for working together. Okay. Okay, so everybody, all right. There's always one. Okay, so this one is a little different, and again, to just check that things are working, this question is, the best thing about the University of Michigan is, and it's completely open-ended, so you can text your answer. Is it the student? Is it the faculty? Is it our wonderful fall weather? Is it the football team? Is it the state of Michigan? And you know, as great. All right, so football seems to be a popular answer, tied with science, faculty, and diversity. And so, what we're going to do as we go through is to give you a few opportunities to throw your thoughts at the wall, and then use those to kind of help guide the discussion. Wow, very cool. Okay, and so switching to our main topic of the day, what about precision health? What do you think about precision health? Is this something you're doing already? Something exciting where you'd like to be involved? There's so many definitions. Which one is it? It's just a fad? Or maybe you're not sure yet, you're just curious. Okay. All right. And so, all right, we don't have the time to go around the room completely, but since the top answer is that you're on it already, maybe if we could just go and get a random volunteer from each table and tell us what you're doing in the space of precision health. That would be pretty cool to just get a survey of where the room is. Anybody want to start it off?
I'm happy to start.
Awesome.
So I'm working in radiation oncology and in the physics, medical physics applications, and we're working on precision medicine with respect to giving patients their best treatment care and combining the information from biomarkers, different types of imaging, pulling that together to deliver customized care and assessing that over the course of patients' treatment.
Awesome. Someone from the next table, we can rotate, I don't know, that way. Any volunteers? Second volunteer?
So our department is very interested in the concept of learning health systems, which is very closely aligned with precision health. We have several projects ongoing, one of which is the development of scalable infrastructure for actually implementing the new knowledge that precision medicine, precision health generates.
Very cool. Anybody at the next table?
I'm Ray DeGreek. I'm from the Center for Bioethics, and as you might expect, my colleagues and I are interested in some of the ethical questions that emerge from precision health. How do you get consent for collecting people's data? What gets done with that data? Who owns those data? And where do they go? So these kind of things are on our radar, and we're starting to work on them.
Okay, and I guess that's one of the really cool things at Michigan is that we have people not just doing the science, but thinking about the right ways to engage people and to do it in a nice ethical framework. And so thank you, Ray. Anybody in this table wants to chime in?
Okay, I'm talking to from College Pharmacy. We are a group of faculty in our department. We work on pharmacogenomics, proteomics, and metabomics based on precision math.
Cool. Anybody here at the front? Everybody's chewing. Huh? You selected E. All right. You're curious. What about you guys? Okay. Okay. So for those who didn't hear, it was about looking at neonates, newborns, and finding out which drugs work well and what predicts when they work. Good. Cool. Anybody in the next table over?
Larry Junk, I'm in neuro-oncology at the Cancer Center. We're just getting started on sequencing key oncogenes in most of the cancers that we treat, and using that information to see if patients are candidates for clinical trials, sometimes to guide towards treatments off trial, and more important than anything, just to make us smarter about the entities we treat. So instead of just being a name on a diagnosis, it's a more complete analysis.
Cool. Anybody here? Margaret.
I've actually two things to say on in my job here. I do Mendelian diseases, and we recently identified like some rare diseases where finding the gene pretty quickly predicted what treatment would work, and they worked. So this is precision medicine on a very, very small scale. But I also am very interested in sort of the general health issues, and I hope to write a book about that during my sabbatical, about using your own SNPs and predicting all kinds of health decisions. And together with some other people here, we talk about the ethics of that as well.
The next table behind. Anybody that's not chewing and wants to try and share?
Jasmine Lewis from Clinical Pharmacy, and my research is pharmacogenetics, so using the patient's genetic profile to hopefully avoid adverse events or infectious syndrome.
Cool. And then I think there's only one table left in the corner. Volunteer from there. No, Rachel? Anybody at your table wants to? All right. Oh, great.
So I work on mobile health, which is this idea of using wearables and mobile devices to capture day-to-day behavioral data and then using that to adapt treatment.
Terrific. Cool. So, so quite a range from cancer to newborns, to data with learning health systems, to ethics, to devices. And this is only a subset of all the things that are going on at U of M. And so you can imagine that when we get together inside the initiative and say, how are we going to do something that's going to engage all the faculty and make everybody happy, we always come up with a magic recipe where we accomplish that. Okay, more seriously. We're going to talk about precision health at the university. I'm going to be presenting. I'm Goncalo Abecasis. Also in the room are two of my co-directors. Sachin is at the back. Sachin, do you want to stand up and wave? Yes. Hi. And Eric Michelson is here at the front from the College of Engineering. We have a couple of key staff people as well in the room. Rachel Dawson in the back is the managing director. She basically keeps us all on check and makes sure things happen. She's been a really great addition. And then Tina Kreger over on the other side is our project manager. And so you will probably initially, since they're the only two staff on the initiative, if you try and get in touch with us, they might be safer points of contact than we are. Okay. Everybody does different things. I also have the things that I do and I'm excited about. I'm just going to do very brief so you know what my biases are. When you see things spinning too much towards data and genomics, you know that that's me putting in my biases. But I run the Informatics and Analysis Center for this large NIH project called TopMed. We've just sequenced our 100,000 genome last week. It's about 10 petabytes of data, 100 million hours of compute. And we are focused on developing tools that let everybody who's contributing to the project interact and use the data. So for example, a tool like Bravo is hosted here at Michigan, lets anybody browse all the genetic variation we've discovered. That little blue square is for a tool called NCore, where people can interactively run analysis on the data, and so on. The other things that I've tried to do is to figure out, how do you generate resources that have many uses and that enable you to do new things with data. And so one of the projects we've done is, for example, on Facebook, trying to engage participants in genetic research. We now have participants in every state in the US. And to engage them, we share information about their ancestry. We collect information about their habits. This one is a curious one. I guess I don't have, oh, there's a pointer. If you look, here's a sleep calendar among all our participants for 2016. You can see they sleep more on Saturdays and Sundays on the weekend. And you can even ask questions, which day of the year they slept the least. You might guess, is it New Year's Day? Is it St. Patrick's? When is it? And you'll see that the lightest colored square, for whatever reason, is this second Tuesday in November. And then you could try and deduce what happened there. All right. Okay. But precision health. Precision health at Michigan is about how we can use advanced tools and technology, sort of broadly defined, to discover how the combination of biology, lifestyle, and environmental factors influence health, and that this will result in knowledge and also better options for each individual to manage their own health and their wellness. Broadly speaking, there are 3 goals we'd like to achieve. We want to encourage collaborative research. Collaborative here defined as bringing multiple people, perhaps people that have different knowledge and expertise and they haven't worked together yet, by building a platform, building infrastructure that makes it easy to do that. And the infrastructure could be places where you can securely share health data. It could be access to health data resources that we're collecting now, but they're underutilized. We hope that if we do this right, it'll be a way to bring in better students and faculty to the university. And we hope that if we do this right, it will also lead to improvements in the health of society, so that we will be fulfilling our mission of furthering understanding and helping the population at large. Okay. You've heard many buzzwords over the years. I'm actually surprised so few people said precision health was just a fad. It's actually a very sane way to think about it if you look at the progression of personalized medicine, precision medicine, and now precision health. But one way to think about it is that, in healthcare, we often make decisions that we say are personalized. They're based on limited information, the data that's on your health record. For the past decade or so, we've been hearing about how we could improve those decisions if we add biological data, and particularly DNA that's easy to measure at scale. And now when thinking about precision health, we want to say, hey, it's not just about what's in your health record and things that are easy to measure like DNA, but let's try and get a more full picture of each person. Let's think about their environment. Let's think about what they're exposed to. Let's think about their social network, because all those things will contribute. One of my colleagues in public health, Sharon Cardia, did this analysis, which I'm sure is incorrect, but she keeps reminding me that your zip code is more important than your genes in determining your health, and for many things that is true, and so we shouldn't just say, these are things that we can measure well and understand, so we'll focus on solving the problem there. We should look more broadly. If we can understand all these things, we can now pick the right intervention for each patient, whether they're a cancer patient or they're a patient that are at risk of becoming addicted to opioids, or whether they're a patient at risk of heart disease or any other disorder. One of our goals is to make it easy to integrate and understand several different types of information, starting with the medical phenotype. You'll hear a little bit about some of the medical phenotype resources that are available already at the university. Family history, genetics, biology, the environment, behavior, and lifestyle. And to say, let's take advantage of both new technologies to measure biology at scale. Let's take advantage of new wearables, new mobile devices to measure other parts of each individual's life. Okay. And so this is, again, another chance to hear what you all think. If you thought about precision health and how we do healthcare at the moment, and you said, what is the biggest thing that we can add? What is going to contribute the biggest advances over the next several years? Is it going to be artificial intelligence? Is it going to be genetics? Is it going to be mobile devices? What is it going to be? I'm really curious to hear the sense of the room. So, nobody responded. I already put you guys to sleep, so the food was too effective at making you docile as an audience. Genomics, electronic health records, machine learning, data, wearables, artificial intelligence, biomarkers, access. And I really like that access one because I think one of the things you'll see that we do a lot is we collect data and we stash it away and it never gets used or thought about in any interesting way. Okay. If you guys want another minute. And so all the answers will actually be recorded and tagged with your, and we can share them at the end. Bayesian methods, environment, intelligence, mental illness. All right. That's right. It doesn't seem very good when it makes these word clouds, is keeping words together. But the good thing is, when we look at the individual answers, we actually will have the phrases. So, thank you. Okay. Here's another take at the foundations of where we try to go to build our vision. Say, let's pick some big problems that we can solve now, we couldn't solve before. Let's do it by engaging local patients at scale and using new technologies and data sources to characterize them. Let's make sure that the data is available to everybody at the university in a convenient and straightforward way. And let's make sure that we build opportunities for folks like all of you guys in the room to come together and find out about each other and work together and share your expertise. And so if we can do that, we hope that we'll have sort of this virtuous cycle where we'll have both discovery, we'll understand something about the mechanisms of disease, about new biomarkers, that we'll develop new sensors and computational methods to make sense of the data, and that we'll have new ways to communicate those results. And all those are kind of basic discovery research. But that will translate into then treatment, so that we have better interventions, that we have a platform for doing experiments on how to improve care. It will also translate into health, because it shouldn't just be about fixing things once the patient is sick, but it should be about how can we enable people to manage their health better. And that could be both through policy reform, and we have lots of groups here who do fantastic research in those areas. It could be to making sure that information and tools are distributed and available and invented. One really nice thing is that, as you go around the university and talk, you find that there's so many cool, amazing things in every little corner, whether it's at the discovery, at the basic research level, whether it's then translating into the clinic, whether it's delivering healthcare, or it's figuring out policy and best approaches there. And and there's really, this is obviously just a sampling of all the different units that are involved, and each one of them are world class. And there's ISR is amazing. The School of Social Work is impressive. The Ford School, public health where I live, engineering where Eric lives, medicine where Sachin lives, LSI, so many amazing parts of the university. Our goal is that this will help research, that we're going to generate new knowledge, that it will help education, it will help us get the best students and faculty, and that it will help service. Okay. All right. So over the past year and a half, we've had a series of meetings, feedback from university executive officers, back to the drawing board, new sketch of proposals, and we've come up with this plan that says, as we go through the initiative, we're going to have these 5 main areas. One, cohort development, you're going to hear a little bit about in a few moments. is going to be engaging local patients in research. So for example, at the moment we have this set of 50,000 individuals who said, you know, I've provided a sample of DNA, it's been characterized, you can use my health data broadly, both what's available at UFM and what's available in other electronic databases. And they've been explicitly consented to do that. We would like to make that cohort more diverse, so it represents not just lucky people like all of us in the room, but it represents people from all walks of life and all their different healthcare needs. Another stream is going to be about making the data available and providing both analytics tools and a compute platform that's guaranteed to be secure. If you've tried to work with patient data or human subjects data, you know there's a lot of regulation about it, around it, and we would like to make it easy to work within the rules, to make sure that the data is appropriately encrypted, that there's appropriate security audits, and so that you can safely access data that might be quite sensitive. We want to enable experiments in how you take this information together, a rich set of patients, the data tools, and then new ideas to change care. And we want to start experiments in educating the next generation so that they have the right tools, that they are able to make the best use of these opportunities. Initially, this will probably start with just a few courses. There's a goal within the 3-year lifespan of the currently funded initiative to also have a certificate program launch. Feeding onto these and sort of interconnected, there's going to be a program for faculty-led research grants. So that will be awarded competitively. We expect that it will be on the ballpark of about $8 billion invested in that stream of for faculty-led research. And we're going to have a chance to dive a little bit into each of these streams, but you know, to get a sense of are there any of these that drive your interest or are you excited about? Here's just a question. If you're going to be involved, which bit would you be excited about? Is it about developing the cohort, figuring out how to engage patients at scale, increase their diversity, collect data on them? Is it about using the IT platform or the data that we're collecting? Is it about new experiments on how you change care for health implementation? Are you excited to teach a new class or get educated yourself or faculty-initiated research? And I think the trend is pretty clear. It's, give me the money. All right. Okay, but we will get a chance to chat a little bit about each of these. I've been waffling for a little bit. If anybody has anything that they want to chime in or break the monotony of my monologue, you know, feel free to interject or raise your arm. Otherwise, I'll continue. Yes?
So the scope of the program you're discussing is about 3 years, at least in its first iteration. And what is the duration of the national program?
The national program? Mm-hmm. Okay, so so what we're doing locally is intertwined with many national initiatives. You know, so for example, you might have heard of the, President Obama's Precision Health Initiative, which is now branded All of Us, and they have a goal of nationally recruiting 1 million individuals to participate in research over 5 years. That's one of them. There's, for example, the Top Med program that I mentioned, where we're working with existing cohorts, things like the Framingham Heart Study, the Jackson Heart Study, the Women's Health Initiative, and adding genomic data to all of them. And that, again, is also multi-year. Here at Michigan, I think we got a commitment to fund this program for 3 years, and then, we hope it will continue. There's some milestones in terms of engaging faculty, bringing in outside funding that the university would like to see. Yeah.
I should preface this by saying that I'm here on behalf of the Center for RNA Biomedicine,
Cool.
which has about 150 faculty
Yep.
associated with it. And I was wondering, so you mentioned the focus on DNA genome sequencing.
Okay, that you know, if I mentioned that, that's not what I was supposed to say. So I think so that was my bias coming across. So I think our goal is where we started. We have samples at scale characterized in terms of DNA because we know how to collect and characterize them at scale. You know, a real clear goal, as we're going to talk about the cohort, for example, is how do we enable experimentation in new data types? And broadly defined, it could be RNA, it could be metabolomics, it could be wearables and mobile devices. But you know, we're only scratching the surface and collecting a limited piece of the picture by if we just did DNA at scale. Okay, so for sure, it's one of the things we'd like to figure out to do. Any follow-up?
Yeah, so because you could argue, of course, that the reason why zip code correlates more with health outcome than the genome is because the genome is not always consistently transcribed. So it's really in the epigenome, the transcriptome, epitranscriptomics, and all these things, I mean, additional data that ultimately determine health outcome.
Sure.
Just as much.
All right. Okay, so one of the foundations behind what we're doing is this Michigan Genomics Initiative. Over the last 5 years, we've been asking patients who come in for surgery at Michigan if they would donate a sample of blood and if they'd give us permission to use a variety of electronic health data in research and also to call them back. You know, sometimes once you've had the first look at their health record, at the DNA, or the blood sample, you say, you know, I really would like to look in more detail at one of these individuals, and we have explicit permission to do that. At the moment, there's 50,000 patients. The 50,000 patient was collected, I think, just at the beginning of November, end of October. And you know, the data set works for a variety of research questions. We have researchers working it to study cancer. We have researchers using it to study liver disease. We have researchers using it to study cardiovascular disease, for example. And we think as we integrate more data, for example, prescription databases that right now are not included within the health system, that there'll be even further research opportunities there. Also wanted to mention in the context of the Genomics Initiative that one of the innovative things that happened there, and this was really because of a lot of ideas from Nick Stanek, a professor of history here at Michigan, that we ended up with a consent form that's all in one sheet of paper, and that's actually, it looks almost like a cartoon. And you might say, you know, you're not being serious about it if you do it this way, but the history of it was that we started off with the traditional consent form that you know, had been designed by the IRB over many years. It was 14 pages. And you know, and participants joined and signed, and then we called them back and said, hey, we'd like to know a little bit more about you. And they would say, what are you talking about? And you'd say, well, you joined this study and you signed up for this. And they're like, what? You know, and if you get it down to one sheet of paper, you increase the chances that people actually read and pay attention and don't tune off. And so when we follow up with participants, we get better results and get more consistent. Hey, I know that I signed up for this. This is not completely out of the blue and unexpected. Okay, so this is just to find out if any of you had heard about the Michigan Genomics Initiative before. You know, it goes from A, you're using it, B, accessing was hard, C, just found out, could be interesting, or D, you know, it seems so different from anything you need that it's less relevant. Okay, and so we need an other.
But I'm not using it.
I'm sorry?
My data's in there, but I'm not.
Right.
Oh, thank you.
My domain's in there, I know of it. But
So the first version of this slide did have an option. Yes, I volunteered, and with 50,000 volunteers from the health system, it's pretty likely that in a room this size you'll have some. Then, thinking more about it, it's like, maybe we don't want to ask research participants to identify themselves. So that's why that option disappeared. It actually was there, and thank you for participating and being generous. So, okay. Another really cool resource at Michigan, and this is really Sachin's brainchild, is this data direct and research data warehouse. Unless you're in the medical school, there's good reasons that you might not have heard about it. And the best among those is that if you hear about it and try to use it, at the moment, it's an incredibly painful process. It took me a year and a half to get access. But when you get access to it, it's an amazing thing, because it turns out that the research data warehouse summarizes a lot of the interactions with patients during their care. We've seen since the database was established about 4 million patients. And you can go and ask questions like, how many patients have had this procedure and also were obese and also had diabetes and also later came back 6 months later for another intervention. And the scale of the data is really staggering, and you can imagine that it's well beyond what you could replicate in a research setting. Our health system spends about $3 billion a year on patient care, and this is the summary of all the patients they come across and all the things they've annotated for each one. There's some things there that are really, really interesting and sort of underutilized. So for example, as part of a conversation with a set of investigators, Session and I found out that about 40% of those 50,000 patients have very detailed images of their abdomen that have been collected, and that you could use, for example, to measure where fat is deposited, whether it's in your muscles, in your bones, in your other parts of your gut, and those seem to be correlated to the adverse consequences of obesity. But through Data Direct, you can reach this, and through basically a point-and-click interface, ask about the data. It will tell you how many patients match. And if you follow up with an IRB application, you can actually get de-identified data about those patients. Each patient's identification has been replaced with a number, but for many research questions, that's quite good. And one goal of the initiative is to say, let's make this database not just a secret that's available to researchers in the med school who have the right secret handshakes, but it's broadly used throughout campus. And so, just as before we had with the Genomics Initiative, I'm curious about whether you'd heard about Data Direct and what's the balance in the room. So, cool. And so, all right, is there anybody here who's not in the medical school who's used it? And I'm very curious to know. Cool, so 3, 4, cool. But it looks like a lot of people have used it, and that's really great to see. And then some of you guys are learning about it, and I guess part of the mission and goal for these meetings is to introduce you to these.
So how can you clarify, because this painful 1.5-year process, is it painful because you're not in the medical school and
yes.
much less painful?
Yeah, so what happened actually was,
okay.
what happened was they said, oh, this is really easy. All you need to do is get a level 2 account.
Oh.
And then getting this level 2 account turned out to be a never-ending loop of who is permitted to, in the end, the reason I got a level 2 account, you appreciate the stories because I mentioned to Gil Oman, I was really frustrated with this.
That's how you became a member of our department.
That's right. Gil sent me a form and said, sign this form. It was like a blank form, and then a couple of days later he said, now you're a member of the Department of Computational Medicine in the medical school. Yeah. But hopefully not everybody has to be assimilated into the medical school to access the data. If you already have a level 2 account, then the short version of what you need to do to start exploring the data is log into the med school VPN, and then go to datadirect.med.umich.edu, and it should be pretty self-explanatory. Erin Kaliba and Sachin at the back can tell you a lot more about it than I ever could. And Erin, do you want to?
Right now, you also, the second requirement in cycle level 2 right now is that you've taken peers training, which is ethical conduct of research training. But hopefully in a month or so, we'll have only a level 1 required, peers.
Cool. And peers is probably a pretty reasonable requirement. But, yeah.
You can take the test together. This is the way it works best.
All right. Okay, so I mentioned we have these work streams, cohort development, analytics and IT, implementation, education, and then funded research. So I'm going to give you a little bit of a flavor of what some of our goals are for each one of those. So in terms of cohort development, we'd like to keep engaging with patients. We want to figure out how to do it at scale and collect richer information on each of them, keep the cost relatively low. We want to go beyond what's in the health record, beyond what we can easily get from DNA, and figure out what are opportunities for understanding exposures, for understanding lifestyle, diet, data biological signals. And this could be broadly defined. It could be both by working with faculty who are just developing new methods to measure these exposures and just developing the right technology, testing if things work, and then figuring out, hey, when these things are ready to scale up, seeing, hey, how can we apply them to thousands of patients that are streaming through the cohorts continually. We would like to figure out how to integrate more broadly. And so I gave you a little flavor of the research I do day to day. Sachin's research day to day is about how do you integrate data across EHR systems? Way back before he became a U of M faculty member, I think he and his brother actually wrote an electronic health record system that they then sold the company to GE. And I guess he decided that instead of living in corporate America, he wanted to be a faculty member. And he came back, completed medical school, and now he's there in sort of almost corporate America now. Anyway, baseline goals: continue recruiting patients from our perioperative process, expand to some targeted clinics, and this is probably something that we're going to look for faculty input and ideas. Our goal would be, faculty experts recruit the patients that they think are most interesting. They get the right consent. They can contribute to the overall effort. Expand beyond Ann Arbor, perhaps to Flint or Dearborn, to make sure we get a more diverse population with different healthcare concerns, different needs, and we're not just studying lucky people like us. Start collecting data with mobile devices, community engagement, and if things go really well, we'd like to, for example, start deploying new biosensors, figure out how to use graphically coded data, and so on. Okay, as you talked about research, you heard me say cool things about Michigan Genomics Initiative, about the data warehouse, but I think it's also really important to emphasize that, as you go across Michigan, you find all these amazing gems. And so this is a slide from the College of Engineering, and it shows 3 of the technologies that they're developing. So these are, at the top, these are really tiny sort of light probes. The scale there, you probably can't read it, but it's 70 micrometers, so something really, really minuscule. And it shines light, and it can be implanted in a brain, and it can communicate with individual neurons and get readouts. Next to it is an example of a very tiny chip. And so different faculty in engineering are trying to develop general purpose chips that use very low power, that can be programmed, that can do a variety of interesting functions, and that eventually will power micro devices, for example, that use those Michigan light probes, or that use this BioBolt, which is also a sensor for activity in the brain. Okay, things that we think are really important to do to keep succeeding and leapfrogging what's out there. Engage with the local community, hospital data providers. Take advantage of the fact that we're really have people that are engaged and that believe in UFM's mission and so are opting in at high rates. Figure out how to we take advantage of these engineering opportunities and expand to cohorts of children. Okay. This one is for IT. I think once you start working with these data sets, it's not practical to say, let's take a 10 petabyte data set and make multiple copies of it. Each one of them costs millions of dollars. We want to figure out how to allow people to work with the data conveniently, securely, and in a way that's sort of cost responsible. So we have a combination of figuring out how to work with public clouds, how to use some of cool research clouds that are local and using systems being developed by some small companies here in Michigan, how to make accessible both big data, HPCs, new modes for data storage and archiving, and combining that with a rich set of tools. Eric, who is got oversight over the advanced research computing effort at Michigan, is really the expert there. And I don't know, Eric, do you want to add anything to what I said and clarify? And
just very quickly. So in advanced research computing, we make available a variety of compute modalities to campus. Many of you may work on this Flux computer already. We do have available already a HIPAA-compliant version of Flux that is called ARMIS. But in the future, under this Precision Health initiative, we will make available many other compute modalities, right? So, Goncalo already mentioned these secure data enclaves. We just spun up a version of that, and last week, I think some of you may have heard that those data enclaves were declared HIPAA compliant. We'll keep on adding to that. Precision Health is about, it's really a story about data, and so this requires incredible data volumes, so we will be acquiring new database facilities, new storage disks and so on. So that's all part of our plans. Okay.
Thank you. All right. And obviously we think there's very nice opportunities to coordinate with other related university initiatives, whether it's MIDAS or Data Science Services, which is the newest iteration of CSCAR, or data science infrastructure that's being developed at ArcTS. Okay. So obviously things that we'd like to do is to take some of the environment and analytic tools that are pretty unique to UFM, whether those that are in Data Direct, those that different faculty have already developed to apply to large-scale projects. So how can we combine them, make them easily accessible on our own data sets? How can we make them easily applicable to other data sets? Support work that's data intensive and computation intensive, but with the special flavor that this is human data with special restrictions on protections, special challenges of scale compared to, for example, what would happen more naturally inside MIDAS. Okay. One of the charges from the university early on was to say, you guys are sketching out this platform. How do we know that it works? How do we know that we're not just building something over many years and that in the end it won't serve its purpose? And so they said, sketch out and work with faculty leaders to figure out possible application areas. We ended up sketching out use cases centered around cancer, around mental health, around diabetes and metabolic disease, and then around opioid abuse. As sort of challenges and opportunities that could take advantage of the patient samples, of the patient data here at U of M, the analytic tools that were being developed, and that would also challenge this idea of how do you go full circle? How do you develop new ideas for intervention and treatment? We presented all of these, and after some discussion, it's very clear that the most excitement, particularly from President Schlissel, was around opioid misuse as an area that's really emerging as a big problem, and where there's probably not enough research, not enough understanding of what could be done. We really want this to be a platform, and so this question is for you. It's to let us know if you are going to use the precision health infrastructure that we've just been sketching out, that's this sort of still just an idea, what would you like to apply it to? Go blue, all right.
Someone who hasn't joined yet. You can clear your response by typing clear.
Oh.
Whoever
Okay, so if you didn't mean to say go blue, but I think it's an important inflection, you can clear your response by typing clear. Okay, and so what's there? Cardiovascular disease, anxiety, clinical depression, pharmacoepigenomics, the environment, mental health, diabetes, surgery, women's health, cancer. So a wide variety of ideas and goals, and I hope that you will give us kidney, that you'll all give us feedback as we go along and tell us, is what we're building really helpful for what you're trying to accomplish? Okay, so why opioids? So the challenge here is that when we start with a new patient, they come in for surgery, they're not currently taking an opioid painkiller, they have surgery, they have another procedure, they go home and they're prescribed painkillers to help recover from surgery. And I guess what we find is that what we find, we generally, this is way outside my area of research and what I understand, but if you follow up these patients 6 months later, 6% of those that were not taking opioids and using them habitually before surgery now are using them regularly. And so they've become sort of addicted, or at least habitual users, and that's the first step towards more serious problems. And so what if we could understand who are the individuals that are at risk? What if we could adjust how we prescribe and how we use opioids when people come to the health system so that we don't contribute to this increasing opioid epidemic? I think there was even just today, there was a very sad story in The Atlantic. There was a long feature about a family dealing with these challenges. Okay. And and then the last two streams in here, and I think after mentioning these, I'm going to go and have a few questions and move on to open discussion, is health implementation. We really need a platform for when any of you in the room has an idea about how can you predict people that are going to have poor outcomes? How can you predict and identify individuals who need an extra intervention or would benefit from it? How do we translate that into the practice of clinical care? Whether by doing a small experiment to prove that it would work, or whether by actually automating it into the health system so that it shows up as a notice to the doctor, and a notice that the doctor actually pays attention to and does something with, or perhaps just information that's delivered direct to the patient. And so part of the platform side here is developing the infrastructure and tools that enable you to plug in new analytics into the care process. And then under education education and training, our goal is to say, hey, let's start developing some courses in this area. Once we have a rich set, and there's already several very relevant courses across the university, let's work to establish a certificate program in this space. Okay, how's this all organized and laid out? So, administratively, the oversight resides in the EVPMA for Medical Affairs Office, so Marshall Runge. It's governed by an executive committee that includes the provost and 4 schools that helped jumpstart the program: public health, pharmacy, engineering, and medicine. We are establishing a faculty advisory committee where we will probably see some of you that will be tasked with giving us big picture advice. Are we doing the right things? Are we going about them the right way? There's lots of choices, because if you said, let's do all the things that Goncalo just talked about, and the set of things that Sachin will talk about in his town hall, and that Eric talked about at his town hall last week, you could easily spend our budget many, many times over. And so we'll be looking for your input in how to prioritize among different options. We currently have years 1 to 3 of funding committed, with the expectation that it might continue, but that we will be required to have demonstration of external support and funding to do so. Okay, so a few open questions to finish it off. What's the most interesting thing from your perspective in all this conversation? What really got you, hey, that's something I didn't know I learned, or that something I'm excited to go and do something about, if from your own perspective? I hope it wasn't food. Data access. Funding. Integration. Codes. Research data warehouse. Open to the world. Pole EV. What's that? Opportunities. Cool. So, anybody want to share their particular interest or even concern or thing that they would have liked to hear but didn't hear? Yeah.
One area is cost effectiveness. For a long time I've thought about the cost effectiveness of maybe the testing plus the therapeutics, but then there's a large information component to this. Gathering the patients and educating them and seeing whether that makes a difference. So I think that's an element.
I think, when we think about intervention or implementation, this is really about thinking about how you use this information in a good way. And you could imagine that people who are developing policy at the law school or public policy or IHPI, those are kind of very natural partners and sets of people that we'd like to engage and say, think about things one could do in this space. If you could really bring them to patients, would it, for a fixed amount of money, would it really improve outcomes, or would it just be a snazzy thing that costs a lot and doesn't really make the whole system better?
Yeah, so I was curious. I mean, I think it's a great thing to take initiative and make this move forward. But I'm wondering also, this is predicated on biomarkers. That is, you can find something that is characteristic of a certain disease type. And that notoriously has been very difficult to pinpoint over the last decades, given that every patient over a period of time or so has changing biomarkers in that blood or wherever you measure them. And there's only very few things that accumulate over a lifetime that might be more predictive. But most biomarkers that are currently in research use are not really coming to the fore because they haven't been validated as biomarkers. So are we, is this a solution before we actually have the biomarkers that would make a difference in the clinical setting?
I see. So I think, basically, this is not a solved problem. So this is a research problem, right? So it's about both identifying the right biomarkers. It's about just discovering new ways to measure things. If the folks in engineering make these probes for the brain work, what does it mean? How do you interpret that data? And it's also true that we shouldn't say that it's all about biology. When we start bringing in geographic data, and you can find out, hey, where did this person go and spend their time? If they're adolescent, how much time do they spend next to the local liquor store or in other high-risk activities? There's many things that we need to learn how to use and integrate. Okay, before I lose the entire room. So previous question was most interesting thing, biggest opportunity. If you were going to tell us, here's one big thing that you guys should pay attention to, one thing that you guys must do, what would it be? What is the biggest, where are we going to get the biggest bang for the buck? So biomarkers. We just heard skepticism about biomarkers, but then, variety of opinions in the room. Basic research, the alternative. As a statistician, I always like the alternative. Maybe the null. Epigenome. Health kits. That's the Apple thing. Cool. And, all right. And then, okay, this next one I think is asking you guys for a little bit of specific. Actually, the next one is the specific advice that I'm sure you'll have more interested in. But this one is, if you were going to engage, you had a vote at the beginning. Oh, I think I'm interested in cohort, or I think I'm interested in the data. I think I'm interested in implementation. But now we've actually gone and talked about it. Is it about doing foundational research? Is it about extending and enriching the cohort? Is it about using the data? Is it about the tools and environments that we're developing? Is it about turning this into patient care? Or is it about the education opportunities? Okay. All right, and foundational research seems to be carrying the board again. Just give it a second for the last stray votes to come in. Yeah. Absolutely. Oh, and sorry. Okay. Now this one is, if you heard, we have this $8 million pool where we're trying to organize a competitively funded research program, and you said, hopefully all of you guys will get a piece of this pie, all right? You'll have a great idea. You'll propose it. It'll go through some sort of review process, and you'll be one of the best ideas, and you'll all be funded. But there is a catch, right? There's probably 50, 60 people in this room, and we only have that $8 million. If we gave each of you guys $1 million, we would have a serious overdraft, and Marshall and Martin would then call into question our management skills. So in terms of thinking, what does it mean to be meaningfully engaged? If you had a research question or an implementation question or a data question in this space that you wanted to try out, is it about a small funding opportunity that maybe would fund a student to work with a couple of faculty? Is it some sort of mid-size where it includes more than just one student? Or do we really need to go and imagine larger opportunities? And it's very curious to see. And it looks like everybody went for the Goldilocks option and went for B. Okay, so I think this is the end of the presentation part. Okay, there's one last question, and then this is the end. Okay, so the last question is, what's your advice for how do we engage all of UFM's community? What's the best way to do that? And while you vote and give advice on that, I'm going to ask Sachin and Eric to come to the front. And then for the last 20 minutes or so, or if there's open questions, we'll take questions. And sometimes I'll be the right person to answer it. But you've already heard a lot of my take on things. And then it'll be also nice to hear what their summaries are. There he is. Okay. And so, okay, any questions, comments, advice? And this is an opportunity for really, if you've stuck around, you should say that whatever you have to say is worth saying. Yes?
Yeah, you look, the program has collected a lot of DNA data, genomic data. Do you have any plan to...
Can you give him the mic?
Okay. So it looks, the program has collected a lot of DNA data and genomics data. Do you have any plan to collect other omics data, such as proteomics data, protein expression, or metabolomics data?
So at the moment, the plans for collecting other data types are twofold. So we are looking for faculty who have ideas on new devices and new tools to measure this data at scale. And once, if there are things that meet a good cost point, whether it's a wearable or a mobile app, or whether it's something that can be assayed in blood, we would like to experiment with doing that at scale. As you can imagine, if we said let's do RNA and expression and epigenetics, soon you run out of money. And there's also the challenge that DNA is very robust, so you can collect a tube of blood, leave it sitting on the counter, and then later extract DNA the next day, and it works pretty well. Some of these other things, there's a process thing about how do you collect them in a useful way. But we really want to figure out how to do this, and we need advice from the community on what they would like to use. Since you guys will have better ideas on what are the opportunities and what's really worth doing.
I'm struck by this being called precision health, yet mostly we talk about medicine and cancer and all kinds of perioperative. I mean, 70% of people's health, by some statistics, we can quibble about that, are lifestyle issues, choices that we make, behaviors that we take, how much money they have available, and that's part of the zip code story, right? So my question is, how can this become a question of precision health when we are actually going basically in the OR to collect samples? And so that's what I would like people to get challenged on. And one group to talk with this might be the healthy aging group, because they have collected large samples and they were getting into it from the healthy aging rather than the sickness. So to me, this is striking that it's called precision health and not precision medicine, yet you're going into the most medical of all places, the OR or the peri-OR area to get samples.
Fair point. Good point. Anybody else?
Is there any way or any plans to make this available to do cohort identification using MGI, kind of analogous to Data Direct, where, for example, I want to know how many patients within the healthcare system are carrying a particular variant for targeted studies?
Do you want me to answer, or do you want to?
That's your answer. I'll answer that.
So the answer is yes, definitely. So we want to make it easy to do cohort identification from both sides, whether to start from the health data and say how many patients have these characteristics, already have DNA, or from the DNA data, let's say how many have a particular variant or have an analyzed sample, and then link it up. And actually, if you go to Data Direct right now, you can already ask the most basic question, which is there an analyzed DNA sample for this person? And our goal is to basically allow you to query at the level of individual variants.
just as one of the tasks is to get the clinical data out of the medical lockbox, another goal is to get the DNA variants out of the genetic analysis lockbox. So how do you unleash that? So that's meeting in the middle is exactly a very near-term goal, not even a 3-year goal. Like literally in the next 12 months, it will expose those variants through data within data directs, curate a control and experimental group, and submit for an overnight GWAS run to Goncalo's servers and make that so you even have to run the GWAS, just like we've done for TopMed. So absolutely, but what we've really learned is how many different ways, and I'm not a geneticist, but how many different ways people can ask for a variant. Some people give you this RS thing, some people give you a chromosome number, some people give you a polymorphism, and getting all those different vernaculars in one place is our current chapter. I think you bring up a great point about precision health and why are we dealing with people who are in the operating room. It was a historical decision purely for operational efficiency. The cheapest and most broad way, actually, as it turns out, going to the operating room is not what is the criteria for entering MGI. If you have a blood, an IV started, which are oftentimes very healthy people need an IV started. So we got perfectly healthy 18-year-old athletes who happen to break their ankle on the football field. They're in there. They're perfectly healthy, and we are now in chemicals. So when we looked at the makeup of this population and compared it to the University of Michigan health system in general, which is a medical care system, so I'll give that caveat, all of the people in the health system are under the medical care system, they're actually very similar. If you look at the demographics of age distribution, disease burden distribution, medication distribution, they're very similar. We fundamentally agree with you though, which is why some of the dollars here are allocated to diversify that strategy. So we're going to clinics, and we're actually going outside the clinic environment. So the work that Goncalo has done with Genes for Good, which is participants who may not even be in the healthcare system at all, need to be part of a precision health initiative. Unfortunately, the amount of money it takes to enroll, recruit, retain, sample, and follow those individuals is an order of magnitude higher. So now that we have some funding, we're going to make some forays into those areas. So we completely agree with you, but I would argue that we also are far more representative of that data set than one would believe, because when we actually looked at the data, it was surprising. Other questions?
I think we can leave the last 15 minutes for just informal discussion. The three of us will be available. Thank you for lasting until the end. Yeah.
You're going to meet some friends there.
I hope you enjoyed the presentation. If you would like to be in touch, the easiest thing to start, go to our Precision Health website, precisionhealth.umich.edu. And just subscribe to our updates. You can also find contact information for me and the other co-directors, for Rachel Dawson. Be in touch. Tell us what you'd like to learn. Tell us how you'd like to be involved.